Well, thanks for coming to the session, and thank you to Chris and Mary for doing the, grunt work in the background that makes it all work smoothly. So I'm Brenda, and this is Meghan, and Brianna Yee, who's part of our group, is also here in the room but didn't want to present. And Kaitlin Sibbald and Tara Pride helped with this as well, and they are both at other sessions at the moment. It's one of those conferences where there's like 3 sessions at a time that you want to be at. So we're gathering today in Mi'kma'ki, the unceded ancestral territory of the Mi'kmaq, and settlers have been gathering here uninvited for over 400 years. So today we're going to talk about M-Mind professionals, by which we mean mad, mentally ill, and neurodivergent, or neurodivergent. And madness refers to a range of anti-psychiatry politics, and it's used differently by different people. And neurodivergence is also a very broad term that doesn't have a consensus definition, but it includes a range of differences in the way people's minds and brains work. And of course, categories always violate people's realities and their self-conceptions. So we want to make clear that not all of the participants we're going to be including in today's presentation might agree with this categorization. For example, one of the participants had a diagnosis of bipolar, but preferred to self-describe as having mental health issues. That was her term for herself. Another saw all diagnoses as highly problematic and unhelpful, and instead understands what we call mental illness as a product of the chaos surrounding living with poverty and trauma. Nonetheless, we're trying to talk about a whole bunch of people today, so we are using the imperfect category. M-Mind, come on in, find a seat. There's no hold up here. To refer to the research participants in our study who self-identified as having lived experience with psychiatrization or being entered into the psychiatric system, and or lived experience with neurodivergence or what some would call cognitive impairment. And as one of our research participants said, it's like the brain gets all grouped into one. Mental health, cognitive, psychological, emotional, doesn't matter, it's still neck up. So the research, this comes from, a couple of people have commented on our study that I've seen the last 2 days. We've been doing a lot of work across Canada with a number of different professions, including occupational therapy. And so this comes from a study with OT, social work, nursing, medicine, academia, and law, 6 professions, 140 participants across Canada. We did qualitative in-depth interviews either in person or by phone. Well, there's folks standing at the back. Do you want to stand? You're welcome to stand, but there's also seats up here if you want. All of the participants in these studies self-identified as disabled, 2S LGBTQ+, racialized, working class origin, and or ethnic minority. And from that group of 140, we had a subsample that changed all by itself. We had a subsample of 12 that we categorize as M-Mind. And they identified with ADHD, PTSD, MTBI, neurological conditions, bipolar, mental health issues, trauma histories, and or depression. Of the 12 M-Mind participants, most were in healthcare and social work, and it's quite interesting to me that no lawyers identified this way. The majority were white, identified as women, and many came from low-income backgrounds. Weird not to be able to see what you guys are seeing. Okay. And Meghan will take over for a while.
Our focus today is considering the occupational injustice of M-Mind professionals, what we face as a form of epistemic injustice and violence, how epistemic injustice, epistemic violence creates contortions in the everyday occupation of M-Mind professionals, creating occupational injustice. So I self-identify, I feel that it's important in speaking to this. I'm a MAD social worker, so my lived experience is also reflected in this work that we're speaking about today. So what is epistemic injustice? Coming mainly from philosopher Miranda Fricker's work, it's a form of injustice that concerns knowing, knowledge, and being a knower. Testimonial injustice is a particular form of epistemic injustice in which whole categories of people are discounted as legitimate knowers. Their knowledge is rendered to be less believable, less credible, and they face what are called credibility deficits because of who they are. Credibility deficits are obviously a problem as professionals. And finally, epistemic violence. This term originated in the work of post-colonial scholar Gayatri Spivak. It means not only denying the legitimacy to the knowing of particular groups, but also imposing a different or preferred dominant way of knowing their own experience. So in this case, when medical knowledge supplants the self-knowledge and community knowledge of people who are mad, mentally ill, or neurodivergent. So what did we find? We'll talk about these themes, the strengths of lived experience, disclosure with colleagues and with service users, perceptions that madness, mental illness, and neurodivergence are incompatible with being capable, credible, and professional, and ways that M-Mind people are disciplined towards professional conformity. People throughout the study were very clear that M-Mind experiences enhanced their professional practice. Their experiences as users of professional services brought a valuable perspective to their work. They thought that they sometimes had a deeper empathy for the people that they were working with and deeper compassion as well for the experiences. They were able to understand and anticipate in ways that people without lived experiences could not. Many had an intense commitment and passion for advocacy, and some found that they could reinterpret and reframe for colleagues the behaviors that some service users had as strengths, resilience, and resistance rather than as pathology. So not surprisingly, disclosure was something that was very carefully navigated among M-Mind participants. With their professional colleagues, most disclosed very selectively, sometimes to only one or two colleagues. For example, one OT said, people with whom I work on a regular basis that I feel I have a trusting and good working relationship with, I feel that people need to know. I let them know, but by and large, I don't tell people. Only two participants were completely open with their colleagues. One working in mental health disclosed right at job interviews. The other disclosed after years of working in a hospital setting and building up trust. And after that experience, that participant said that 75 to 80% of her colleagues started to tell her about their own experiences with psychotropic medications. So with service users, most people said that they do not disclose with emphasizing that the relationship has to be centered on the service user. So as one OT said, ethically, I don't ever want to tell them too much because I don't want it to become about me. It's never been about me. And when I'm with them, you can't really cross that line into revealing too much. Some disclose only when it will benefit the person they're working with. So as another OT said, I almost never disclose to clients unless I feel that it has some bearing on my connection to them or their sense and trust in me or understanding that I actually can empathize. And Brenda's going to take back over for a minute here.
So when it came to disclosure, the real issue for participants was that they feared being seen as incapable, crazy, unreliable, and unprofessional. One academic said, that's why I haven't disclosed to anyone, because people would just be like, oh man, she's crazy, you know? She's not capable of doing anything. Or we're afraid of her because she's crazy. And OT said, they might think that I'm dumb or in general not reliable, or I'll have a history of forgetting things or making errors. Another said, it's one thing to know it. It's another to see the symptoms. I'd be afraid clients would shut down or think this person's not professional enough. Participants were afraid that accessing accommodations to which they had a legal right would come at the cost of being seen as less capable. Professionals are supposed to be these selfless superhumans who are hyper capable and work long hours, juggle competing demands, and therefore accommodations get constructed as coddling, cocooning, and spoon feeding. As one physician said, it's that Protestant work ethic thing of, even though I very strongly believe in providing opportunities for people who are traditionally excluded from spaces, the idea of taking one for myself feels icky. It's just like, well, I don't need this. I'm doing pretty okay. Another physician who had taken time off after a workplace trauma and returned to work too soon was struggling with their PTSD. And when asked if they ever took other time off after that, they reported quite proudly that they had never taken more than a couple of days at a time. So it's this kind of narrative here framing themselves as the good professional by not taking needed time off. So participants questioned whether Memind people were seen as lacking credibility too. People were not believed about their own conditions and capacities, and they were assumed to lack knowledge and insight into themselves. So one OT said, a professor told me to my face that he didn't believe I had condition and that he shouldn't have to provide the accommodations that the university was asking for. I actually invited him to come to my next medical appointment. Being challenged by someone in that position of power made me determined to not share that information with employers or people in positions of authority over me. And in professional education programs, people were treated as if they were trying to get out of doing the work, as if they were being deceitful somehow. And people described being infantilized, babied, and seen as objects of pity. Folks also questioned whether people who are identified as mad, mentally ill, or neurodivergent can be seen as also being professional. They said their education programs contained virtually no discussion of the possibility. One nurse, for example, said, obviously I can't be unwell and be a nurse and like speak from a place of truth with my patients. I knew I wasn't well. I knew I was depressed. And a physician said the idea of a physician and a healer being sort of calm, stable, steady person, you know, being like, and by the way, my brain is different and kind of broken if I don't manage it, kind of destroys that illusion of the rational other. Another physician had asked at work about the possibility of bringing in a service dog, and just asking the question raised all these alarm bells, and suddenly there was a flurry of excitement about, we thought you were doing okay. And it was like, you can't both be working in your job and asking about needing a service dog. Those are incompatible. So because of this perception that people can't be both a service user and a professional, participants felt at risk of losing professional credibility if they were seen by others at medical or therapy appointments. For example, a physician said, I'm a medical health clinician, and seeing a medical health clinician myself, I could have bumped into potential patients and different things in that area. That didn't happen, but those are potential ethical conflicts. What would I have done with that? Being both service user and professional destroys that myth of an us-them separation. A social worker, for example, who found herself in a job where she was working closely with the staff of another agency where she was a former client, found that that staff was very uncomfortable with this situation. She said, I don't like the us and them thing. I think professionals have that to protect themselves from the vulnerability of seeing the possibility of ending up in a negative situation or sick or something. How do you cross over? It's like you put a big wall up between the people who are suffering and the people who are helping them. How do you jump the wall, right? And the disciplining, what we call the disciplining of mind conformity, of professionals who identify as mad, mentally ill, and neurodivergent for being outside of normative expectations, was sometimes through very concrete structures, like being challenged for taking all of your sick days or being unable to predict well in advance when you might not be able to come into work. A really clear example came up from this physician talking about licensing forms. In terms of mental health, that's not something I would ever formally or publicly identify with. It's not safe to do so within medicine. Like, there's a question every year on the licensing form that says something along the lines of, do you have a mental health condition that would impact your practice of medicine? And I would answer no every year, because that can greatly affect a person, the ability to practice. The same point was echoed by a social worker who noted that in the social work licensing form, the mental health question comes immediately after the criminalization question, which kind of brings up all those tropes about mental health and criminality. That person went on to say, I had 1 year where I was off part of the year, so yeah, it interfered. Did it interfere in my judgment? No. Did I compromise any ethical issues? No. So what are you asking me? Are you asking me whether I had a back problem and had to be off work? Because it's the same thing. Okay, occupational contortions isn't really a thing. We made this up, but it's a fun term. And what we're trying to get at here is the way some professionals are compelled to twist and reform their everyday work occupations to fit normative expectations and the invisible work required to achieve this. For example, some people had to construct for themselves what ethical practice looks like. If you refuse to abandon this, to engage with this us-them divide, if you don't fit in with normative expectations, people had to work extra hard because they weren't doing the accommodations that they were entitled to use. They had to not just do their jobs, but work at presenting as if they fit with normative expectations, the way they were expected to appear. when academics said, I'm constantly trying to sort of censor myself and hold back the huge amount of energy and manic energy that's going out there. And I spend so much time and so much energy thinking about how I'm interacting, how I'm going to be perceived. What is an acceptable way to behave so that I won't upset people or have people think negatively of me?
So how are these themes related to epistemic injustice and epistemic violence? In the West, the notion of professional is equated with being impartial, rational, objective, expert, and authoritative. And people who are M-mind are viewed as unstable, unreliable, unbelievable, emotionally or cognitively compromised simply by virtue of their M-mind status. Research has shown that professionals are expected to not just be capable, but to be hyper capable, selfless superhumans, capable of hypernormative physical, psychological, and cognitive performances, working long hours, juggling all of our competing demands. While M-mind people are viewed as incapable, incompetent, unwell, needing treatment, needing therapy, and there's this impenetrable divide that might be assumed between those who provide care or services and the professionals and those who receive care or services, the patients or clients or service users. So you are either a service user or a professional and never both. It's kind of an us or them. So M-mind may be considered incommensurable with being professional. So one concept that came up was epistemic violence in our weaponization of insight. If you resist this framing, you will risk being perceived as lacking insight. Marie-Pierre Rivest argues the concept of insight gets weaponized against M-mind people, used to epistemically disqualify their knowledge as legitimate. People are seen as showing higher levels of insight when they accept the dominant understanding of their experience. So if someone sees their distress as illness and complies with a particular treatment regime, they are seen as having insight. Whereas if you push back, if there's symptoms that come up from a particular treatment, or you just don't want to do it, you're seen as having no insight. When people resist this, this is seen as a way to justify these kinds of diagnosis, distrust, and denying of their credibility. Insight gets used to delegitimize disagreement, which is a clear case of testimonial injustice, where the credibility of an entire group, including is discredited about their own condition even. Oh, I don't know how that happened. Okay. So, oh, there we go. Occupational injustice. In the professions, occupational performance relies on credibility. It's a basis of taken for granted trust, authority, and expertise. The demand for conformity leaves M-mind professionals twisting and contorting in their everyday work to avoid or minimize loss of credibility and legitimacy. That is injustice. Oh, my goodness. Did that progress for anyone else? There we go. Okay. So our conclusion, the disciplining of professionals towards conformity with narrow conceptualizations of capability constitutes occupational injustice for those who identify as mad, mentally ill, or neurodivergent, imposing on them unwanted occupational contortions while negatively shaping the meaning of everyday work occupations through the risk of marginalization and loss of professional credibility or epistemic injustice. There's, yeah.
Thank you. And we have extra minutes. We spoke fast. So we have, I think, 7 minutes? No. 4 more minutes. We have less time than I was supposed to. And I think Mary's going to run with a microphone. Is that true? There was a hand near the back. She's scared of the mic for those who are listening in virtually. There we go.
I was just wondering if you could talk a little bit about the definition of mad. I haven't heard this term being used.
Certainly. So MAD is MAD or madness is a reclaimed term to describe distress. So a lot of what we would consider mental illness can also be framed through the term of madness. So the MAD movement encompasses MAD and people with psychiatric survivor histories of being psychiatrized. In the academic sphere, it also references people with anti-psychiatry work as well. So it's a reclaimed term and also a term for mad pride as well. Yeah. Reclaiming our space. Yeah.
Way over here, Mary.
Thank you for your presentation. I was wondering how we can break the stigma, like what action we can do to break the stigma around it.
Megan's doing it right now. Be a professional. When it's safe, own your space as a mad, mentally ill, or neurodivergent person. There's a hell of a lot of us out there, and because we don't talk about it, it's like it's this hidden thing in the room. But I swear at least a third of every cohort that's gone through our school in OT has identified in some way with mental health issues. And so there's a lot of OTs out there, and yet we do this thing where I get to be my mentally ill, mad, or neurodivergent person when I'm at home, and then when I'm at work and I won't be that. That's what I would say. Megan, do you want to add to that?
I would just say that the unpacking the stigma is just the start. There's a whole realm of experiences that occur because of saneism, so oppression based on the dominant assumption of what it is to be normal or to be professional, and also neuroableism, which again, for the people who are neurodivergent. So the stigma is just the first step, and it often doesn't go deep enough to really get to the root of the oppression. So we have to go deeper and be willing to go deeper.
That's the when it's safe enough to be out. It's not usually. No. There was another hand over here. Do we have any time left? 1 minute. Right over here, Mary.
I was going to try and quickly ask two questions. One was, what do you think of using the term crazy in psychiatric settings? And two, can you offer any hope for a student about to graduate that may identify as mad that, yeah, is hoping to be able to express herself that way? Yeah.
Yeah, I would say not a fan of the term crazy. Some people, use it towards themselves, and if that's how someone is self-identifying, that's great. If it's an active choice that's being used. So sometimes in the MAD movement, people will identify as being, well-educated crazies, and if they want to do that, then that's their choice. But again, it's coming from the person and not something being applied to the person. And in terms of hope, I would say, we live in a really dominantly biomedical frame, and there is work to be done, but there are also so many of us who are showing up and willing to do the work. So find your people. Find your people, and that makes all of the difference. Yeah.
She's calling time. She is the official timekeeper. Thank you very much.